Welcome to today's SHIP webinar on telehealth implementation. We're hoping today that you'll get a better understanding of the basic of telehealth services, as well as how telehealth plays into the SHIP program in your state, and how you can most effectively use SHIP funding to implement those telehealth services. As a reminder, we do encourage participation on these webinars. We want to hear from you and hear your stories at the state level, so feel free to at any time ask questions, put something in the chat, or raise your hand if you have something to add. So that we get a better sense of everyone who's in the room, please put your name, your state, and your organization in the chat, like so. This will also help us capture attendance. So, for example, my name is Caroline. I work at the National Rural Health Resource Center and I reside in North Carolina. If you would like to utilize closed captioning, there's a button on the bottom of your Zoom controls. Let me know if you need any help. Feel free to use the chat box as stated, and then we are recording this webinar. It's going to be shared in the listserv and posted on the center's website. Just a reminder again to take that polling that's being launched. Your feedback that you provide through these webinars helps us inform future programming that we offer to you all at the state. So we want to hear how you like things and what you're taking away. Just a few announcements and reminders. Before we get started, TASC is hosting a Sustainable Rural EMS Workforce webinar next Wednesday, November 6th. That email invite went out to the AllFlex listserv, so if you need it, just let me know, and I can share it with you. NCC season for SHIP is approaching, so keep in mind that SHIP TA is here to support you in any way that we can, so just reach out to us and let us know what we can do for you. We are going to send out some information, and Krista will send out some information from FORP regarding the NCC soon, but just keep in mind we're going to have a webinar on December 3rd for the NCC. And then a final reminder is use the Flex Forum. There's actually an area in the Flex Forum that's dedicated specifically to SHIP. And we hope that you all are using that to communicate with each other at the state level and ask questions. We've seen a little flurry in the last few days of use of the forum, so we want to keep that up and then check it out and see if you have anything to add to the ongoing discussions. Again, if you need access to the forum or you're not sure how to use it, just reach out and we can get that rolling. So with that, I'm going to turn it over to Caleb, and thanks for taking the pre-polling, and we'll get started.
Thanks, Caroline. Just a reminder, we will start with a video from Mike Rowland, one of the program specialists on the Delta team here at the center. He was unable to join us live, but recorded us a little video to talk about telehealth, some of the intro, basics, fundamentals, things like that. And then we'll transition to discussion of some of the allowable investments as it relates to SHIP, and then kind of close out with some discussion and questions and answers from you guys as coordinators. So reminder that participation is helpful and beneficial for not just you with your questions, but for your colleagues as well. So there's some discussion about this as well, but I thought it would be helpful to have the definition of telehealth there on the screen so we all know what it is we're talking about. Let's get our video started. Caroline?
My name is Mike Rowland. I'm the telehealth specialist with the Delta Region Community Health Systems Development Program and the National Rural Health Resource Center. I'm a master's in public health with a background in rural health and public health. I started working in telehealth, specifically focused on building learning collaboratives to take specialist level knowledge and train primary care teams. I'm currently working in a myriad of different digital health initiatives focusing on implementing innovation and technology in rural spaces. Currently, I work with approximately 30 healthcare teams across the Mississippi Delta region to provide guidance and implementation aid for telehealth programs across systems as big as federally qualified health centers or as small as a single provider rural health clinic. I'm really happy to be presenting to you guys today. Okay, so on today's call, I'm I'm planning on breaking down a few of the instrumental aspects of telehealth. To do that, we're going to speak about telehealth background and telehealth modalities. I'll also be talking about some of the baseline telehealth programs that we see and the innovation and technology that's supporting them. Last, I'll give a few notes from the field on challenges and successes that we traditionally see from our telehealth teams. Okay, so let's start off at the start. So what is telehealth? It's a simple question with a not so simple answer. The common misnomer is that telehealth is just a simple video call from a patient to a doctor, commonly a PCP. However, the complexities really surround the definition, including how the technology is used and who's using it. Systems like remote patient monitoring for chronic conditions, virtual therapy sessions for mental health, school-based telehealth, inpatient specialist consultation for specialties like cardiology or neurology, and educational resources for self-care are also a part of the telehealth ecosphere. Additionally, a subset of telehealth includes telementoring, which enables healthcare providers to learn from experts online, enhancing their ability to manage complex cases. Overall, you should know that telehealth has broader use case environments than the simple provider to patient visit. When we talk about telehealth in practice, it's important to know how these services are delivered. And there's two main methods. There's synchronous and asynchronous. Synchronous is like having a live conversation with your doctor. Imagine you're having a video call with your physician, discussing your symptoms and getting that immediate feedback. Some of the use cases surrounding synchronous care include primary care, urgent care, and in most cases, specialist visits as well. On the other hand, asynchronous care doesn't happen in real time. Instead, it involves sending information back and forth at different times. For example, you might take a photo of a rash that you have on your skin and send it to a dermatologist. That dermatologist can review the image and later send you their diagnosis and treatment plan. This is particularly useful in fields like dermatology and radiology. In radiology, a technician might upload your x-rays or MRI scans to a secure system, and this radiologist, who could be across the world, can review those scans and send you back a report or send back the clinician that's working with you a report. Radiology, this system has been around forever. We didn't have, this advanced telehealth definition behind it, but it definitely has majority use case as far as asynchronous style telehealth. And another kind of level setting component that I like to talk about is telehealth locations. These really come into play whenever you're speaking about billing. So it's really important to think about these as being separate areas of focus. They're generally three location areas that we like to think of. The first one is a distance site. In rural healthcare, the distance site always refers to the location of the healthcare provider that's delivering telehealth services. This could be a specialist in a city hospital or a healthcare provider in a rural clinic. For example, a cardiologist in an urban hospital can be providing consultations to a patient in a remote area, ensuring they receive that expert level care without the need of long distance travel. The originating site is where the patient is located during the telehealth encounter. In rural settings, this could be a local clinic, a community hospital, or even a patient's home. This setup is particularly beneficial for patients with mobility issues, being at home. But the originating site is always going to be that location of the patient. The presenting site is a specific type of originating site where a patient is with a health professional who assists in presenting the case to the distance site provider. Often we think about this whenever we think of patients that are in an ED that are presenting with symptoms that require a specialist consultation. Telestroke programs work with this system of a presenting site. In addition, psychiatric services that might be occurring in an ED, those definitely have a presenting site where there's a clinician that's facilitating the conversation back and forth between the patient and provider that's at the distance siting. Okay, take a step back and just talk a little bit about the history of telehealth, because I always think that people kind of start off thinking that telehealth came from an urban space. And although technology comes from an urban space, it's kind of a misnomer that telehealth was really built around distance, and so rural drives telehealth. In fact, telehealth saw some of its earliest developments by NASA during the space race. NASA's collaboration with Indian Health Services in the 1970s led to a project called StarPack, which was using telemedicine to provide healthcare to remote Native American communities in the American Southwest, showcasing the potential of technology to overcome those geographical barriers. And really, if you think about it, both some of the technical aspects of provisioning care in some of the canyons and some of the spaces. I actually traveled out to the Four Corners region and worked with patients at IHS, and it is as remote gets. And so some of that work really did help to establish and understand what kind of barriers exist to communicating far distances. In addition, added in a second point in here about telehealth. Obviously, is championed well in urban spaces, but it still thrives in rural ones. In some ways, it's been built out of necessity in rural spaces. A primary example that I found was from the early days of the internet, included the Alaska Federal Healthcare Access Network, which has been connecting remote communities with healthcare providers since the early 2000s. And telehealth builds on its roots with rural innovation, where it was initially developed to overcome geographical barriers. The COVID-19 pandemic rapidly expanded its use, demonstrating a critical role in modern healthcare. So everybody knows that telehealth had a massive uptick during COVID. But where are we at now? So COVID didn't create telehealth, obviously, as you now know, but it certainly accelerated its adoption, almost like taking off the training wheels. Even though we've seen a decline in telehealth usage in the post-COVID world, it still remains incredibly impactful. Telehealth continues to enhance access to specialized healthcare services, especially in rural communities. I actually put in this slide, so the data that you see on the slide is from one of our Delta healthcare teams that works in the Mississippi. You can see that we've obviously seen a spike right during the heart of COVID, and then from there we had a drop off to some extent. That doesn't mean that the services aren't being used. It just means that the services are being more flexed to be used in different areas. In this case, you can actually see that another service line was developed during COVID, or excuse me, during the post-COVID time point. And that's what we really started to see, is that more of these hospitals, rural hospitals included, have started to see telehealth as being this advanced function that doesn't just have to live only in primary care. I found a quick article in here, just McKinsey and Company article that highlighted the telehealth usage surge during COVID-19 pandemic has since stabilized to levels significantly higher than before. This continued utilization demonstrates telehealth's lasting impact on improving healthcare access, outcomes, and affordability. And as I said, this is equally what we see. We aren't going back to pre-COVID days. We know that telehealth is a useful tool, and that's kind of where most of our hospitals are staying, although we're using it in a more flexible way at this point. Okay. So this brings us to our next topic, surrounding the current state of telehealth. While it's true that telehealth is experiencing a bit of a post-COVID hangover, we're also seeing some really exciting advances in technology that are significantly impacting our healthcare organizations and our teams that we work with. So let's dive into some of the ways that those are impacting. First, we'll talk about specific service line development, like growth in primary care and a push for these patient-centered medical home, or PCMH models, due to the expansion of value-based care. We'll also talk about behavioral health because everybody's talking about behavioral health right now, along the lines of the increased demand and tech-driven solutions. And then we'll talk about technological developments and how EHR-based telehealth platforms, digital front doors, and AI dictation systems are adding to that toolkit that all the providers and healthcare teams are working with. I also want to speak a little bit before we end on rural healthcare challenges and some of the ongoing barriers to care and some of those notes from the field, those real world insights that we're seeing from some of our healthcare teams. Okay, so first off, just to speak on primary care, obviously, as I spoke about before, primary care still has a pivotal role in both being an entrance and a grand facilitator for telehealth programs. Often, primary care acts as an initiator for better utilization of care networks, ensuring patients receive comprehensive and coordinated care. This is a foundational role, and it's crucial for improving healthcare outcomes and managing patients more effectively. In this context, that PCMH models are particularly effective. With the expansion of value-based care, there's an increased push for utilization of these models. And by leveraging telehealth, PCMH models can facilitate a better continuum of care for patients. Telehealth facilitates this by simplifying that virtual consultation process, which allows the primary care provider to maintain care for complex patients, meanwhile simplifying and consolidating the patient care channels. In rural healthcare, this can increase patient follow-up and decrease bypass rates. We see a lot of these PCMH models that have been initiated at federally qualified health centers, at FQHCs. And they do have a great leverage point because FQHCs really have a primary care driven model. And so a lot of that medical decision making is occurring at a primary care level. Why not simplify it by trying to keep the patient closer to home? Because we, as pretty much everybody knows, the referral channels are often overloaded. Patients spend a lot of time waiting to get into referred specialist appointments. So PCMH models, a lot of that is born out of some of the ACA, and we hope that that is a continued trend because it has a lot of flexibility within the telehealth space. The next topic is a very important topic for most, a significant rise in demand for behavioral health services post-COVID. We've seen notable increases in cases of anxiety, depression, and substance use disorders. The surge highlights a critical need for access to mental health care. One of the advantages of behavioral health telehealth is its cost effectiveness. Unlike some of the other telehealth services, it doesn't require expensive peripherals, making it a lower cost option. This can help to reduce overall cost of care while still providing an essential service. However, there are still challenges to address even with this service line. Finding qualified health providers for telehealth and behavioral health can be difficult. Additionally, contracting to external services can be costly, which may limit access for some patients. Understanding these factors can help as you work through with your teams and learn to improve and expand telehealth services to meet the growing demand for behavioral health care. I think one kind of note that I want to add in is that whenever thinking about service lines, I added in some service lines that often are seen as kind of those low-cost entry points to telehealth. They don't require a whole lot of input. A lot of those teams already exist within healthcare systems. So often these are our first go-tos with sites whenever they really look at what services they want to both create or expand. So I would keep these in mind as being great start points before somebody goes out and says, hey, I want a cardiologist in order to, fill this gap in service. And then you find out that they actually have a very small needs base for cardiology support, and it might be very costly. So I'd keep that in mind. Okay, so next up, let's talk about scaling telehealth services. So it's important to note that not all telehealth services look alike. For example, primary care, those behavioral health components, they just need that simple, HIPAA-compliant video system. On the other hand, advanced systems that connect with patients like stroke patients, neurologists, cardiologists, they may need advanced peripherals. Peripherals, normally, whenever you think of a peripheral, you might think of like a mouse. But in this case, I'm referring to things like a digital otoscope or a digital stethoscope, or maybe even a retinal camera. Those things connect back to a computer system, and then from there, they're able to send all of that data to the clinician on the other end, be it video, be it audio, data, whatever's being created by the peripheral. Those can often be some of the expensive components of telehealth systems. For the purpose of this discussion, I just want to focus on some of those simplistic models, primarily in primary care and behavioral health. One of the key advantages of these simpler models is the utility of some of those embedded systems. When telehealth systems are integrated into an electronic health record, they keep clinicians close to their patient records, which helps to mitigate data loss. This integration also reduces the need for additional training, as the clinicians already know their EHR system, so they're pretty comfortable with working where they're at. Moreover, embedding that telehealth in the EHR can future-proof healthcare establishments, preparing them for impending AI systems that will make connected telehealth the gold standard. That's kind of one of those things that we're starting to see pop up, is even in rural healthcare environments, more and more teams are starting to embrace embedded EHR telehealth platforms. They don't have all the bells and whistles, they're not super expansive, but we know they're eventually going to get there. And with the expanse of AI, where it's going to go, getting farther and farther away from the EHR makes it trickier to bring the data back in the long run. So centralized systems are often where I'm pushing some of our teams to stay, if at all possible. Okay, let's talk a little bit more about some of the extra tools that we have. That's digital front door. So digital front door technology and patient engagement systems are really transforming rural healthcare facilities. These technologies are streamlining and automating processes that normally just absolutely they kill some of the front desk staff, and they're making them more accessible and more efficient. Digital front door technology enhances patient access and engagement by providing online appointment booking, telehealth services, and comprehensive patient portals. These tools reduce barriers to care, especially in rural areas, by facilitating timely and convenient access to healthcare services. Patient engagement systems play that critical role in streamlining workflows and improving patient and provider interactions. They offer user-friendly interfaces and personalized services that enhance patient experience. By empowering patients to manage their health through these digital tools, these systems increase patient engagement and lead to better health outcomes. What we see is that right now, there are third-party tools that are out there that are working on digital front door and patient engagement, but we do think that EHRs are going to have a more expansive list of digital front door tools, especially around scheduling and the notification systems. A lot of these tools are really going to automate that process. And EHRs have already started to build in a lot of AI automation that is probably going to take a lot of that weight off of front desk staff. So speaking of AI, so let's talk a little bit about the integration of AI systems. Currently, we're seeing tech move pretty quickly. And I mentioned a couple of them, but one of them that I haven't mentioned yet is AI integrated dictation systems. Those systems are catching those conversations that are occurring between providers and patients, both in office and via telehealth. They are taking dictation and formulating them into charting. And clinicians are very happy with the dictation systems. What they're ending up doing is saving the provider time and completing a lot of the charting and allowing them to really focus on patient care. So we do see that as a new tool in the arsenal that is probably going to be pretty impactful in the future. Additionally, those scheduling systems, as I referred to before, optimizing appointments, reducing no-shows, sending reminders. We've even seen some of the more advanced systems that are working with patient charting to pull out notifications associated with follow-up appointments, maybe lab work. So some of that, it still has a ways to go, and we think that there will probably be more EHR integration of those systems in the future. But for right now, it's still pretty exciting to see some of those tools come around. Okay. So almost done here. I just want to discuss some notes from the field. So let's discuss, and one thing that I want to put out there, it's important to recognize that telehealth success looks different for each organization. Some hospitals are very much invested in high revenue dependent and dependent service lines, and only see success when a service has deliverable ROI. Others might create telehealth service, not for the initial ROI, which might be slim to none, but for the downstream effects. And the tools and technologies that we discussed, such as each service line developed and patient engagement platforms, which help to build the weight of patient education systems. I just hope that everyone takes away that educated patients are better served for healthcare systems and more effective in its use, be it patient portals or whatever tools they have at their disposal, which in turn can aid their overall ROI, the hospital's ROI, because that patient is using care more appropriately. And one last thing before I go, I hate to be Debbie Downer on this, but developing out telehealth service lines does come with challenges. One of the single most challenging aspects is provider buy-in and contracting. This challenge is even more pronounced when it comes to tele-specialty services like telecardiology, which are both expensive and difficult for rural health teams to bridge to. While it can be done, it's not typically the first step we promote when developing telehealth programs. We generally kind of see, tiered approach to what might be a start point for telehealth teams within the Delta program, and developing out specialty use cases, working with contracted providers. It's often one of the most challenging aspects. Bridging out to tertiary care facilities to try to find those providers, or looking at those contracted services, can be very expensive and time consuming. So we often push teams to try to stay in those early inception components, primary care, behavioral health, or just working with the channels that you have to see if you can increase telehealth to an added service for something you've already got. So with that, I hope you enjoyed the presentation today. Don't be afraid to reach out. I love talking telehealth, digital innovation, and speaking about all things healthcare and rural health. So put my contact info on here, but don't be afraid to give me a call. I'm really sorry I couldn't speak in person today around Q&A, but yeah, don't be afraid to ring me up. Thanks so much. Bye-bye.
Awesome. Thank you, Caroline. Thank you thank you, Mike, even if you're not with us today, for recording that. I want to provide the opportunity for anybody to add some comments, questions, clarification points. Not that Mike is here to answer those, but we will gather all of the questions you guys have and forward those on to Mike, where he's available beyond today to answer any questions. I thought there were a lot of things that I took out of that video that I think would be beneficial for our discussion, especially related to the additional benefits downstream that we can hope to achieve from integrating teleservices from our hospital. Caroline, thank you for adding that question. Has anyone here not utilized telehealth services? I don't know that I have, personally. Jill says she has not. That seems like a fair amount of us haven't. And others, I suppose, have utilized telehealth services personally. Some at the beginning of COVID, but not since, some just recently. All right, so here's back to our slides. We're, reminded of the definition of telehealth. I was really excited or interested in the patient interaction portions that Mike was talking about, the patient portals, the educational aspects that could be beneficial. First person recently to have a telehealth appointment in our rural library. That's awesome, Mary. I forgot that libraries are a great opportunity for this. They have quiet rooms that you can reserve, and often laptops and access to internet that you might not have access to. Even sending photos of skin things via patient portal is a good idea. Thanks, John. So what does this mean as it relates to the SHIP program, and how do we support these efforts through the SHIP grant? So as we know, training, hardware, software that supports the application and implementation of telehealth or telemedicine is allowed. Tablets and hardware and software are allowed if they are used by staff to improve the operational efficiencies and telehealth services. We had Mike referenced peripherals like the otoscope and these other specific to the procedure equipment that is not allowable, but the things to allow the telehealth visit to happen are allowable. There's a link there in this slide deck, as well as Mike's will be available later, but there is a link here to the allowable investment search tool within our website, which really allows you guys as coordinators or hospitals to search through the tool to see what is and is not allowable. So some of those descriptions and examples are the carts for free movement of telehealth software. So the computer on wheels that you would put in front of me as a patient is allowable. The cameras and microphones and connections and things are allowable. The training for the utilization of these services, for computerized physician order entry implementation and training. So there's that level of detail within the search tool. On our next slide, we have a breakdown of the amount of hospitals over the last few years who've been utilizing SHIP funds for implementation or support of their telehealth services through the ACO category. And you can see in 2021, that was almost double what it has been the last handful of years. And it's came down some in 2022, but it's still the highest category in that funding cycle at 231 hospitals in FY22 were utilizing SHIP funds for their telehealth services or telehealth implementation of services. Some different examples of the ways that the SHIP funds can be utilized. So software licensing that provides secure HIPAA compliant services for each provider using virtual care appointments. So Mike talked about the importance of the HIPAA compliance when you are looking at additional telehealth software. Updating that hospital telehealth software or hardware can also assist with care coordination. So we talked about discharge follow-up appointments, and think of an AI or a computer generated phone call to confirm that appointment is on Wednesday at noon, and push pound or something to that effect if you have an issue or would like to reschedule. Hardware support for the use of telehealth services. Hardware and software for the telehealth platform emergency services, as well as education for the telehealth use. So how do we educate our patients and our providers to utilize these services? Mike on our recording had a fair amount of examples or discussion about the connection to behavioral mental health. That's another opportunity for utilization of SHIP funds. And as we know, that's a very big area of interest and need and opportunity for support as we continue to effort the improvement of social drivers of health, but as well as our community and population health efforts. You can expand different service lines and specialty services. The weekend pharmacy coverage, think of the accessibility of having a pharmacist there. Yes, it is possible to change your current SHIP activities. You just need to talk to your project officer and clarify what the steps are to do that. Do we have a bit more clarification of that question, P. Ramirez? Oh yeah, Gail, thank you for that comment on radiology studies and telehealth. That's a great example of telehealth. Remote patient monitoring is another example of, go ahead.
Hello.
Hello.
Hey, Caleb, this is Eva.
Hey, Eva, how are you today?
Good. How are you doing?
Not too bad.
Okay, I've got a question. So if we're able to change, and I'm sorry I didn't type in the chat, but I'm having some IT issues, but is it possible to, when it's possible to change the current SHIP activity, but could we use these allowable examples? Like if we had a hospital that said, well, now I want to, since this is available, I'd like to focus on expanding telehealth services for behavioral health. So we can change it that way?
See if
Amend it. Yes? We can't hear you.
There you are.
Yeah, I'll take that one. So yes, assuming that the hospital is compliant with the priority requirements first, and then there are funds left over, they are absolutely able to change activities, move things around. We are coming up to the midway point in the year, so we generally discourage folks changing activities just because, you know, by the time they get something implemented, can they really spend down funds in the last 4, 5, 6 months if they don't have enough time? So follow up with an email with your PO, and we can have a discussion, you know, and this goes for anybody, you know, if your hospitals ever want to change activities on anything, just shoot your PO an email for that conversation, and then you'll document it in DCP, whatever that change is. So, but yeah, it's always possible to change activities. We just generally try to do it earlier in the project year, and really try to discourage it in the last few months. So, but could be an option. So just send us an email. It's always really specific to the facility and the time of year.
Yeah, I get that, but sometimes some of the hospitals are already doing something like that and just want to count it towards their SHIP dollars. So that's why I was asking.
Thank you, Eva. Any additional questions right
Thank you. Thank you.
Yeah, Caleb, I had someone message me wanting to know some clarification between telecommunications and telehealth. In the allowable investments PDF, we clarify that telecommunications is not an allowable SHIP expense. And so I'm gonna encourage Krista or Janine to clarify me on anything that I misspeak on, but it's my understanding that telecommunications are the systems that you use to provide telehealth services. So like Wi-Fi, your phone bill, phone lines, while telehealth is actually providing those services.
And I would clarify further, telecommunications could even be something like Zoom, and that is not an appropriate telehealth platform. So something like that would not be allowable, but a HIPAA compliant telehealth platform is. And if you look on the search tool, just pop in telehealth, it'll come up with examples of hardware, software, as well as under subscriptions where it talks about telehealth platforms. So it does have to be a specific telehealth platform rather than just a general telecommunications, like a Zoom, a Teams, or something like that, that would not rise to the level of that HIPAA compliance.
Thank you. And let me, again, if you have questions, just feel free to come unmuted, or you can message them to me and I can field them to the group.
Yeah, So what are you hearing? What are you learning about telehealth? Has anyone, any other ship coordinators out there, have you been supporting your hospitals in the implementation of telehealth and want to share how that's going? Are you hearing awesome things or difficult things? What are the types of interactions you're having with your hospitals about telehealth?
I can share something. I'm Sam from Wisconsin. We had a couple of hospitals last year that went with telehealth as an investment. One of them was really excited about it because they used the SHIP funding to help get telehealth equipment like the carts and stuff to equip telehealth oncology unit in their hospital, and they're a very remote hospital. So they were able to then provide chemo to patients in their communities. So they were really excited about that use of SHIP funds. On the flip side of things, we also had a hospital that really struggled to understand the no direct patient care side of don't use your SHIP funds to employ a telehospitalist. And then we went down the list of allowable expenses and they just about gave up. So it's been a mixed bag using telehealth as a SHIP allowable investment between absolutely get it and makes a huge difference to their community and absolutely don't get it and get very frustrated about all of the nuances of what can and can't be used.
Yeah, thanks, Sam. Those are great examples of that. And by those two examples, I'm understanding that you guys utilize individual hospital grants as opposed to a consortium approach.
Yeah, so we've been giving direct awards to each of our most of our hospitals. We have one network project this year. So hospitals are allowed to choose their own investments and choose their own adventures, which is also an adventure for us.
And you guys are a state with a bunch of hospitals which can make that additionally cumbersome, if nothing else, right?
Yeah, we have 66 SHIP hospitals.
Yeah.
So it is there is a lot of technical assistance involved in allowing hospitals to choose telehealth as an option when you're doing direct investment, because there's a lot of hand-holding involved, because what we've found is the hospitals that receive SHIP funds, it's the kind of amount that they really do appreciate getting, but it's not enough to have somebody study the SHIP investments deeply enough to have an understanding of the nuances. So that then falls to the state office or whoever's administrating the SHIP grants. So yeah, telehealth has been a huge help to some, but it isn't very clear, and hospitals don't have the time for the return on investment to understand what is allowable.
Thank you, Sam. That's a great example as well. And I'm sure it has to do with that hospital's place in the journey of telehealth implementation and where we can support this. Like you said, if they've got a bunch of different things and they can utilize this service for this, then awesome. But if there's some misunderstanding or some education opportunities there, that can take a little bit of time to get that dialed in correctly. I was really encouraged by the amount of different services and different opportunities that were highlighted with telehealth, from the primary care and behavioral health that we've all heard of, but the EHR embedded systems that allow for additional patient education and those patient portals, as well as verification of payer or insurance provider things. I wasn't personally as familiar with that level of I guess, integration of telehealth services. So it speaks to Sam's point of there's a lot of opportunity there as it relates to telehealth, and getting that technical expertise and support for your hospitals as well as you guys to clarify what are the allowable investments from the SHIP grant is helpful, and then expanding beyond that, because SHIP isn't the only opportunity to expand these programs and services, but it's one that can be really helpful. So where are those gaps that SHIP funds up to this point, and then there are additional opportunities beyond that. What other questions do we have? Do we have anyone on the line that utilizes a consortium approach to their SHIP program and has had any success with telehealth programs?
In Mississippi, we use a consortium model. It's been successful under ACO just with the hospitals getting training on implementing telehealth models and then just getting the hardware and software that they need.
Okay, I like that approach, Alessia. So everybody kind of participates in getting that foundational, fundamental understanding of what telehealth is, the programs and services that it supports, and then additionally beyond that, then we can support some hospitals or some of those guys getting some of the equipment as well.
That's correct.
That's awesome. Cool. What questions do we have about telehealth, especially as it relates to the SHIP program and implementing programs and services? We had one question about a hospital wanting to change their activity in midway through the year. So we've got some examples of opportunities there.
This is Stephanie. Can you hear me?
Hey, Stephanie, how are you doing?
Hey, this is Stephanie from Oregon. I just had a question. When they change activities midpoint through the year, we also have to be careful of supplanting, right? Meaning that they already have something budgeted and then they switch it to the SHIP grant. Isn't that something that we also have to be cognizant of?
Yeah, so I think that would be where Krista said, yes, kind of depending on understanding what the plan is and what the budget is, what's been spent, what hasn't been spent. So I think there was a yes, but with some pretty specific caveats in there.
Okay. And then on the example that you gave with the telehealth embedded in the EHR piece, so in that regard, and I guess it would probably depend on a case-by-case basis, but could a hospital in theory then allocate their EHR bill if that wasn't something that they were already planning to fund, or if they planned in advance, like the cost of that, if it was, I guess, would it have to be pulled out separately in the way that they pay for it? Or could they put a portion of what they pay for their EHR towards SHIP if their EHR is capable of being sort of the platform that SHIP will allow for?
Those are very good questions, and I'm very appreciative that I saw Krista.
I unmuted so fast. So
I know that probably means no, but I want to know why.
Yeah, so I'm gonna cautiously say yes. Send me the documentation, like if they have an invoice or something, and then the justification, but it sounds like I'm leaning yes, but do follow up with an email. And again, this goes for everybody, whenever you can provide that information for us, we can take a look at whether it's, invoices or a scope of work or what exactly the integration is used for, right? That justification that it's for, quality and experience and, those kind of things, improvements, operational efficiencies. That's what we need to see those keywords. And so that's where a follow-up email is really helpful. But yeah, it sounds like from your brief description, yes, but I'll give you the for sure yes in an email.
Okay, good. And I think for us as SHIP coordinators, the takeaway is just to make sure that the connection to whatever the platform is tied back to the core values of SHIP or the core categories. So as long as they can tie it back to that, and then you can actually see the actual, what are we paying for? What are the funds actually getting allocated towards? That is the kind of backup documentation you would need to be able to better understand.
Yeah, exactly. And oftentimes we don't even need that much. If they have it handy, that really helps us. But you know, unless there are some other programmatic requirements happening, we don't always need that documentation, but it helps provide that justification and shows how they're able to delineate the ship expenses.
Got it. Thank you so much. That really helps. I appreciate that.
Thank you, Stephanie. Thank you for the questions. And those are great example questions for you guys as newer or coordinators that you don't always know and appreciate what questions you have. So as you familiarize yourselves with both the SHIP program as well as the telehealth opportunities, do let us know what questions you have. Forward those on to shipta@ruralcenter.org. We will answer what questions we have the ability to, get clarification from our federal project officers where we need that, and then provide that answer back to you. The recording, both Mike's recording and slides, as well as the recording of this webinar, will be available shortly on the SHIP website. What else was I thinking? As well as just a reminder that the allowable investments search tool is a great source for some of this additional beginning information. So as you develop more questions from that search tool, as well as the telehealth resource toolkit that Sally put in the chat box, do let us know what questions those help you establish and develop.